All right. Well, first I want to say thank you for inviting me to talk to all you guys today about recognizing stroke. As Dr. Mensa mentioned, my name is Erika Dillard, and I have a background in neurosurgery, which means that I've had the opportunity to take care of stroke patients along with a multidisciplinary team in the acute care setting. So I was very happy that she asked me to kind of talk about this subject as well, which hits close to home as well because my father back in 2006 had a stroke and had a very long road in terms of his rehabilitation, has definitely had some post-stroke disability. So definitely have very firsthand knowledge outside of my taking care of patients, but firsthand personal knowledge of stroke. So moving forward, let's see, there we go. So there are a couple goals that I wanted to make sure that we achieved by doing this presentation. Number one, I want everyone to be able to define what a stroke is, not just what a stroke is, but what it is not. We have a number of different terms that are used to replace the word stroke. Some of them are actually correct, some of them are not. So we just want to make sure that everyone is on the same page with the terminology. Also want to make sure that everyone is able to appreciate what the major causes of stroke are, as well as the risk factors. As the title mentioned, we want to definitely specifically be able to identify when we or someone else that we know are experiencing signs and symptoms of stroke as it relates to what the underlying pathophysiology is of the disease. So that just means what the abnormal manifestations of a particular disease are, being able to recognize those. And lastly, we want to be able to understand what the key components are in stroke management, not coming from a physician perspective, but as a patient even, we want everyone to have a little bit more knowledge in what their care is in whatever disease that they're encountering. And so we want as a patient to be able to understand what your initial workup is going to be when you have a stroke, and to understand what the possibilities in terms of treatments are, whether they're medical treatments, meaning medical in the form of pills or medications, or if you actually need a surgical treatment for stroke. And over the past couple of decades, stroke has become more of a disease that can be surgically managed, as we'll talk about a little bit. And so in addition to these 2 points, we want everyone to be aware of what your follow-up will be after you have a stroke, which is just as important in terms of outcomes. Missed that. Oh, whoop, don't want to go past. Okay, so what is a stroke? Again, we want to make sure that we address what a stroke is. So what is the definition? It's in layman's terms, it's the death of brain tissue, which is caused by a lack of oxygen. And as we know, there are different types of blood vessels that supply oxygen to tissues, and different blood vessels that take oxygen or take blood away from tissues back to the heart. Because it's a disease of the lack of delivery of oxygen, it's typically a disease of arteries and not of veins. Now, that's not to mean that there aren't strokes that can be caused by a vein, but they're much more rare. And for our purposes, we're going to really focus on arterial disease. Other common terms that are used to also signify stroke are, you may have heard brain attack before. And you may have also heard brain ischemia. It's more of a technical term to describe the loss of oxygen to the brain and the injury that occurs because of that. And you may have also heard CVA, or cerebral vascular accident, just basically injury that involves the vasculature or the blood vessels in the brain. So what is a stroke not? We often hear the term mini stroke, or TIA, or transient ischemic attack. By this definition, transient, it means that you may you may experience symptoms of a stroke that come, but then actually go, and that person may return to their normal baseline behavior or baseline activity. And by definition, that's not a permanent injury. What you should know, though, is that a mini stroke or a TIA should alarm you that there may be a possibility that you will develop a permanent stroke or damage to the brain. So while it's an emergency, if these symptoms occur, just understanding the terminology and the definition, you should know that a TIA is not actually real damage to the underlying brain tissue, but a marker of the possibility of that happening. So in this slide, I wanted to kind of spice things up a bit. Yes, that's me in the slide. I thought it would be helpful to kind of give you an idea of, in a more of an animation, the different types of stroke. So the major type of stroke we've just discussed is ischemia or ischemic stroke. It makes up 85% of all strokes. And I want you to think about it in terms of, say, for instance, you are drinking some freshly squeezed juice and you're drinking it through a straw. Normally, that straw is patent or open, and so the fluid, the juice, is able to flow through the straw from the end all the way up to your mouth, so you're able to take a sip. But what if you have that freshly squeezed juice and there's some seeds in there? So those seeds will go through the straw. At some point, they may get lodged in the straw, and that will cause you to not be able to get any more juice from the bottom underneath the seed where it's lodged past the seed to your mouth. So this may be a point of frustration for you. This is very similar to how an ischemic stroke occurs. A clot can get lodged in an artery, and at that point above or below the clot, blood will not be able to pass that point. So the area that artery delivers blood or delivers oxygen to does not receive its appropriate supply of blood. Another type of stroke is called a hemorrhagic stroke, which makes up 15% of all strokes. And so in this case, blood is for instance, in the animation in a straw, juice is able to flow up to a certain point, but if there's a break in the straw, that juice flows out of the straw, it spills out, and it never reaches its destination, which is to your lips. In a case of a hemorrhagic stroke, you don't have a blockage such as a clot, but what happens is there may be a weakness in the blood vessel that causes an opening to occur. So the blood will be able to flow through the artery, but once it reaches that break, it spills out into the surrounding brain tissue and it never reaches its destination. Some of the common causes of hemorrhagic strokes are high blood pressure. A lot of people are on blood thinners like Coumadin or Lovenox, and so those can increase your risk of having a hemorrhagic stroke, as well as some patients may have abnormal blood vessels to begin with, such as with aneurysms or AVMs, which stands for arteriovenous malformations. Just kind of looking at this a little bit in more detail, not to harp on this, but I just want to drive home what ischemic strokes really look like in terms of its pathophysiology. So on the far left, all of these are arteries. On the far left, you have a clot that has moved into an artery. At a certain point, it gets lodged inside of that artery, and blood is unable to flow from below that blood clot above. That blood clot probably came from some other location, may have passed from the heart up into the arteries that supply blood to the brain. These are called emboli, and these are very common in patients who have underlying cardiac disease like AFib, atrial fibrillation, or other rhythmic abnormalities. Another way that ischemic stroke can occur is if you have stenosis or a narrowing of the blood vessel. So let's think of it in terms of that straw that we were talking about. If you have a straw and you bend it a little bit and there's a kink in that straw, the fluid might not be able to get past, or the juice that you're drinking may not be able to get past that kink to where it's supposed to go, so you're able to drink. So think of a stenosis very similar to that. It's an area, a localized area that's narrow so that blood is unable to pass appropriately past that point. So in terms of arterial disease, you may have a plaque in the wall of the artery, which is caused by atherosclerosis. And sometimes that plaque has little debris that might break off from the plaque and travel to other locations where it can also get lodged, just like an embolus, and cause worsening deficits because blood is cut off even further down the line to certain areas of the brain. Another way that stenosis occur is not from the inside of the artery, but actually from the outside of the artery. So think of, say someone has a tumor that is growing very slowly, and eventually it pushes on the artery. And at that point where it pushes, it prevents blood from flowing past it. So this is another way that you can develop a stenotic area in the artery that can cause an ischemic stroke. So to put in perspective the burden of stroke in terms of the economy, in terms of health, about 800,000 Americans have a stroke each year, and that's every 40 seconds, basically, someone in the United States will have a stroke. That's very significant. And of these 800,000 Americans, about approximately 142,000 Americans will actually die each year. So this makes stroke the fifth leading cause of death. And every 4 minutes, putting it in time perspective, every 4 minutes in the United States, someone will die from a stroke. The highest death rate are found in Black and African American populations for many different reasons. Stroke is also a major cause of disability, and that disability may manifest in the need for long-term care after the event happens, and also in terms of decreased mobility of the patient who suffers a stroke. This can lead down the line to a decrease in, life outcomes or quality of life. And altogether, all of these components together really put a burden on the economy in the United States. And we see typically about $34 billion in healthcare associated costs each year that goes towards stroke and issues related to stroke. So risk factors. There are a lot of risk factors out there for stroke, but I want to break them up into two groups. One based off of just general demographics of the population, so age, gender, and race. In terms of age, there are there are populations in the younger population that are at risk for stroke, but more times than not, it's the older populations that are at higher risk. And in fact, between the ages of 55 and 85, every 10 years, you double your risk for stroke just based off of age. In terms of gender, at younger ages, men have a higher propensity for stroke. But once you hit over 55 or so, that evens out equally between men and women. But of note, women typically have worse outcomes and mortality rates from disease from stroke. So that's definitely something to remember. And then, as we talked about before, in terms of race, your minority groups have a higher risk of worsening outcomes and risk of developing stroke. So at the highest of that are, again, your Black and African Americans. There are some genetic issues that might lead to a higher risk for a family history of having stroke. One I can think off the top is are patients who have sickle cell disease. And so moving on from demographic risk factors, thinking about your treatable and modifiable risk factors. These are things that you can actually do something about with your healthcare team to change your risk of developing a stroke. Excuse me, and those range from high blood pressure to heart disease, to high cholesterol, diabetes, obesity and diet, which can be modified through exercise and what you eat. Also, smoking is a huge risk factor for stroke, and the use of illicit drugs, specifically cocaine, can increase your risk of developing a stroke. So down to the meat of the presentation, since what we were talking about is your ability to recognize signs and symptoms of stroke, I want to touch a little bit about what signs and symptoms, what groupings there are of signs and symptoms of stroke. So first, you may have heard the term constitutional symptoms. This just means symptoms that are non-specific. So a severe headache can be a sign of stroke, but a severe headache can also be a sign of a lot of other things, including, dehydration, a migraine. So it's quite nonspecific, as is confusion or dizziness. But if you couple the presence of constitutional symptoms with localized symptoms, then you should have a little bit more of a heightened awareness that the symptoms that you're feeling could be attributed to a stroke. So for instance, when we talk about localized symptoms, we're talking about things like numbness or tingling on one side of the body, changes in your vision, not just blurry vision, but if you think about vision changes that you may have decreased vision on one side versus the other, or you could have double vision, specifically in looking in a certain direction, that double vision might increase. So these are more localized signs and symptoms. A loss of balance or coordination could point towards a stroke that might be happening in the back or the base of the brain. And then you have your FAST symptoms, which FAST is just an acronym that was created in a campaign to increase the knowledge out there in the general population of symptoms that can be caused by stroke, and to help the general population be able to recognize those symptoms a little bit better. So jumping into what FAST actually stands for, F stands for face. So facial weakness or facial droop is a sign of a stroke. And the way that you can elicit this response is by asking a person to simply smile. You should be able to see that one side will go up in a normal smile, and then the other side will have some weakness. And so you'll see some asymmetry or difference between the sides of the face. A stands for arm. So if you ask someone to lift both of their arms, the range of weakness that can be observed could be from anywhere from not being able to lift the arm at all, but being able to lift the arm and noticing a little bit of a drift go down as a person tries to maintain the strength to hold both arms at the same level. S stands for speech. So there are different ways the speech can be affected by a stroke, anywhere from having slurred speech to having an inability to form sentences, to even being able to actually speak quite fluently, but that fluent speech be very strange or almost like gibberish, not making sense. The T stands for time. So the key here is, if you notice that someone or yourself are having any of these signs or symptoms, you don't need to waste time. You should call 911 immediately. The fact is that if one of these symptoms are present, you or whoever is experiencing them will have a 72% chance of developing a stroke. So I wanted to provide a little bit of a video. I think I'm more of a visual person, and I guess I just assume everyone is, but I think a video just kind of drives home some of the points that I'm trying to make, and puts it in perspective of a real person who may be experiencing some of these symptoms. So first, I want to describe on the right. It's a sophisticated study that we use in neurology that is called an angiogram. And basically what it does is look at the blood vessels, the patency of the blood vessels, and the pathway of the blood vessels. So one thing that you'll notice is that at the very bottom, there's a larger artery that leads up to very much smaller arteries that supply different areas of the brain. That larger artery is one of the carotids, one that you may hear quite often as having implications in the development of stroke. On the right side, and just notice that your left is actually the right on the picture, and your right is actually the left side of the brain in this picture. But on the right side, based off of the imaging, you'll see that there's a lot of little squiggly lines that go all the way out a little bit further from the larger artery. And so that's normal. You should see those arteries light up in this study. But what you will notice is that on the left side, there's a cutoff. One of the arteries is cut off. There's no more blood that you can see flowing through that artery that's supplying the left side of the brain. So there's a blockage. It could be from an embolus. It could be from a thrombus. But for some reason, there's a blockage right there that's preventing blood from flowing past that point. The left side of the brain typically controls the right side of the body. So in this video I'm going to play, you'll see what happens when the left side of the brain actually has a blockage and is causing stroke. For this patient, you ask them to raise their left arm. They're able to raise the left arm. When you ask them to raise the right, they're unable to raise the right side. So they have right-sided weakness. You ask them to raise their left leg, they're able to raise the left leg. But when asked to raise the right leg, they're unable to raise the right leg. Again, they have right-sided, contralateral, or opposite side disease, unable to lift that side. And sometimes you'll see that the right arm is worse than the right leg. See, the patient is hardly able to lift the right arm. The next thing is to check for sensation differences. So on the left, when you tap them, they're able to feel that, but when you do that on the right arm or on the right leg, you don't see any movement. They're unable to feel the sensation. So if you ask a patient to smile, what you'll see, as we talked about before, is that when they smile, the side that's weak is drooping compared to the left side. This is very typical of brain injury. What's also typical about this is if you ask the patient to raise their eyebrows, they're actually able to raise both sides equally. So this also points towards a brain injury. One thing we also do, as you can see, is that you try to give the patient a stimulation that kind of makes them alert and look towards one side. So what we just saw was when we pointed a finger at the patient on the left, they looked over towards the left, right? But when you point towards the right, they don't notice that there's anything going on the right-hand side, so they almost ignore or neglect that side. And the last thing is if you use a Q-tip, excuse me, I think we went back a little bit, hold on. If you use a Q-tip to provide stimulation to the eye, as you see both of the eyes closed because the patient is able to feel sensation on the left eye. Now, if you do that on the right-hand side, this corneal reflex is what we call it. When you press the eye with on the right side, they don't feel that sensation, and so they don't have a response to close the eye. So, you know all the information in terms of what to look for, what symptoms are most common, but what do you do after you notice that someone has these symptoms or you yourself has these symptoms? Well, FAST is an acronym to recognize symptoms, but it also is really giving you direction on what you should do. You should act fast. The reason for this is the best outcomes in patients happens when you treat your symptoms within 3 hours. So you want to make sure that as soon as these things are noticed, you call for help immediately. If you are having symptoms or someone else you know are having these symptoms, call 911. If you're alone and you're able to get to a phone, again, you should call 911. The next step, though, is very important, and this is not something that is explicitly recommended, but if you are experiencing a stroke, as you saw in many instances, you have weakness that might develop. It might not be the first sign, but it might be the second sign or the third sign that happens with the stroke. What you don't want to do is be walking around and walking up the stairs or trying to walk around to find someone to help you. What will happen is you will probably fall and cause worsening injury. If you're walking on the stairs and you start to experience weakness on the right-hand side suddenly, your fall could definitely be detrimental, and you can cause worse outcomes and worse injury, maybe even a brain injury from hitting your head on something. So make sure that you get help immediately, call 911, and at that point, wait for the help to come to you. The next thing to remember is, or you may be asking yourself, is who is going to take care of me once I call for emergency, right? So the first line of help is going to be your emergency team. Once you make that 911 call, someone will come to you and they will pick you up in an ambulance, more than likely, to transport you to a higher level of care. Those are your emergency medicine techs, and they are well equipped and knowledgeable have been trained in being able to recognize symptoms of stroke. They're also the first line that will alert the hospital that, hey, I have a patient that I'm concerned is having a stroke. Can we go ahead and mobilize our care team so that when they get there, it decreases the amount of time that it takes for them to get the appropriate care. When you get to the hospital, more than likely you're going to be approached by an emergency room or ER physician who also is well trained in recognition of stroke. That person is going to be responsible for alerting the stroke team, which is made up usually of a neurologist and maybe even a neurosurgeon. As I said before, there are more ways of treating stroke now than there were in the past. It's not just a disease that's treated with medication. It's actually a disease that can be treated with a surgical intervention. So it's very important that your neurosurgeon, or maybe even an interventional radiologist or interventional neurologist who is well trained in the ability to do this procedure, is available to also assess you when you get to the hospital. So the way that the stroke team gets on board is through a stroke alert. And that stroke alert, those health professionals have to follow a very specific protocol. Now, this protocol might vary from one hospital to the next. And I'm not going to get into every single detail about what that entails, but what you should see on the top of the screen are numbers from 5 to 45 to 60. That's minutes. So when you hit the door in the emergency room, you should immediately, if there's a concern for stroke, there are certain milestones that should be achieved during 1 hour of your visit as soon as you hit the door. Again, time is brain. So you want to make sure that you address each of these points extremely quickly, or as quickly as possible, as humanly possible in the emergency room, so that you decrease the time from the door to the time that treatment is given to the patient within an hour. And so some of those milestones here are just from when the stroke alert is called and your healthcare team, the stroke team, comes to your bedside to see what's going on with you. That person is going to ask you questions. They're going to ask you about your history, what medications you take, what diseases you have, if you've ever had any surgeries. Another thing that's not explicitly talked about is that, hey, the patient just came in, and if they're having a stroke, they may not be able to talk or speak for themselves. So it's really important that there's someone there available, whether it's a family member or someone who knows you well, that can actually tell the doctor, yes, they're on a blood thinner. You should know that. And they just took the blood thinner this morning. It's really important to have someone available that can be your advocate in that situation. Another thing that's important through the stroke protocol is the NIH stroke scale. So based off of your exam, there is a scale that is utilized in order to predict or better predict what your outcomes overall will be after having a stroke. So that scale ranges from 0 to 42, and the higher you are on that scale, the worse outcomes you will have. And so each point is added based off of what symptoms or signs the physician picks up on when they do your exam. You'll also get blood work, and you'll get a scan of your head. The scan of your head is important because these symptoms could also be caused from other things that are happening inside of your brain. They could be caused from a brain tumor. They could also be caused from seizure. Which might not necessarily be shown on the scan, but a brain tumor most definitely will. And so those are going to have very different treatments. So you want to make sure ahead of time that you know what you're actually dealing with. And so all of these things, again, should be done within an hour from when you hit the door in the emergency room. Once you have all of these initial workup done, then this is going to give you a better treatment plan, or a better ability to have a treatment plan based off of your needs. And so again, I'm going to keep saying it, time is brain. So the longer you wait, when you notice symptoms, the longer it's going to be before you get to the hospital. And then you still have a whole hour for workup, at least once you get to the hospital. So if your symptoms developed over 4.5 hours ago, you might not be eligible for some of the medications that are given more commonly for strokes, such as a clot buster. The other term for clotbuster is the lamest term, but the term for that is TPA. And it's a medication that is given through an IV line that will help break up any clots that are there. Now, it's not 100% effective. You know, more than probably about 50 to 60% of patients will actually get relief from the delivery of a clotbuster. But this is one thing that is absolutely necessary for the physician to determine whether or not you're eligible for that. And one thing that makes you not eligible for that is if you get to the hospital too late. So time is of the essence. Outside of TPA or clotbuster, you might want to make sure that you have some additional studies. If you, in fact, are thinking that this patient is having a stroke, you need to know what the blood vessels look like. So very similar to that scan that I showed you earlier, your physician, your neurologist will probably order something called a CTA. That's going to take shoot some dye into your IV and light up your brain, the vessels in your brain, and so you'll be able to point out where the blockage possibly is. And if there is a blockage, it's also important to know if the brain tissue where that vessel is supplying has already died, or if there's also brain tissue in that area that's still salvageable, that hasn't died or lost too much oxygen yet, where now it's has permanent injury. So all of these things are very, very important, and based off of the outcomes of those studies, you may be eligible for a procedure called a mechanical removal or thrombectomy. Again, this is done by your neurosurgeon, your interventional radiologist, your interventional neurologist, but it's a procedure in which you're able to remove the clot directly from that artery and restore blood flow through the artery. That will help decrease the amount of brain tissue that is affected from the stroke. Sometimes you may have to get further clot buster, but this clot buster, instead of going through an IV in your arm, will be delivered directly into the area where the clot is. So this is another way that your surgeons or your interventionalists are able to treat a stroke. And also sometimes the artery that is being treated may narrow a little bit and might require a stent to be placed. Much like patients have a cardiac stent in their heart, in the arteries in the heart, there are also stents that can be placed inside of the arteries in your brain by the same type of procedure. So as we continue through the management of stroke, once you have your treatment, whether it's TPA, whether it's a surgical intervention, you're not out of the woods, and it's important to know. Once you get that treatment, you're not going home right away. And this is very important for your outcomes. After treatment, you'll more than likely be admitted to the hospital, and it's important for you to have some type of supervision by a healthcare professional to make sure that you're not developing any further symptoms after the treatment has been given to you. More than likely, if you have surgical intervention, you'll be placed in an ICU for a couple of days, or sometimes you may be placed in a stroke unit with very trained nursing staff that are quite familiar with the treatments and care of particularly of stroke patients. But you can pretty much assume that if you've had a stroke, you'll probably be in the hospital for at least 4 to 5 days, maybe less if you're doing great, but more than likely more than 5 days. You'll also, after your initial treatment, will need to get some additional studies. And this is important to understand the underlying causes of why you had the stroke in the first place. So an MRI, which some of you may have had yourselves, you'll get one of those studies done. It's basically that tube that's very closed in space study where you're kind of pushed in there on your back. It's very loud because the magnet that moves around your body is helping take a picture, a very detailed picture of your brain to look at the soft tissues. And so an MRI will illuminate how much of the brain was actually affected after you had the stroke. And if you had treatment, you should see that a lot of the brain was not affected. So this is the picture that you see in the middle is actually a picture of a brain after a stroke occurred. You'll also need to get workup of your heart. An echo is often done in order to look for heart abnormalities. because underlying heart abnormalities are a major cause of stroke as well. As we said, patients who have arrhythmias such as atrial fibrillation, or patients who have enlarged heart may have higher risk of developing clots that are sent through the bloodstream to the brain. And you also need to take a look at your carotids. Again, carotid disease is one of the major causes of stenosis. And so this is something that's actually treatable, but you need to know that it's there. So you need to have further studies to take a look at that. The specialists, while you're in the hospital, that you'll likely see to guide your treatment after you leave the hospital are going to be your cardiologist, again, if you have an underlying heart abnormality, or also your neurologist will be very closely involved in your care after you have a stroke and once you leave. So establishing care with those individuals is going to be very important, particularly in reviewing your medication history and making sure that you are on appropriate therapy going forward. Some of the common therapies that a person may be on for an extended period of time after they have a stroke are antiplatelets. And antiplatelets are aspirin. You may hear a lot of patients on aspirin taking every day after they have a stroke. Or you may need to actually be on a real blood thinner, such as Coumadin, specifically if you're a patient who has propensity for embolic events or clots that go from the heart and up to the arteries and get lodged in the arteries in the brain. Anticoagulants are the treatment for that. And then after you have been admitted to the hospital, if you got your workup and you're ready to leave the hospital, your follow-up care is just as important in order to make sure that you have the best outcomes that you possibly can have. And so the goals of follow-up and long-term management are really majorly twofold. They're to prevent any future stroke from happening, and they're also to help you achieve the best quality of life that you can. And so in order to do those two things, you will have established a healthcare team that will help you address those along the way. So establishing this care before you leave the hospital going forward is very important. Again, we talked about your neurology or your neurosurgery individuals that may be involved, your cardiologist, but also your PCP. The doctor that takes care of you on a normal basis will need to coordinate all the other issues that you may have, or diseases or morbidities that you have, whether it's diabetes. All of those things need to be taken care of in conjunction with now having had a new diagnosis of stroke. So it's important that those taking care of you in the hospital communicate these things to your PCP. In terms of achieving the best quality of life, you have to really think about your physical therapist, your occupational therapist, your speech therapist. They're the ones going forward. More than likely, as a stroke patient, you're going to experience some sort of dysfunction or disability. It might not be permanent, but these are the individuals that are going to help you get back to some sort of normalcy, whether that's back to full dependence or just minimal, or full independence or just minimal dependence from your caregivers or your family. But these are the ones that will help you get to establish a better quality of life. You may have therapy that's in the inpatient setting right around the time that you had a stroke, or you may have therapy sessions that are in an outpatient setting after you're discharged from the hospital. There are individuals that have long-term needs that might not be able to be managed at home, but don't qualify for admission to the hospital. So they may actually have a discharge to a long-term care facility, like a skilled nursing facility, where they will also continue to have therapy sessions in that setting as well. Unfortunately, patients who undergo stroke might develop mood or behavior changes. And so psychiatry might need to be called upon to be a part of the healthcare team to help manage those issues. And also patients who have decreased sensation on one side of the body sometimes will develop pain syndrome going forward. And so pain management might be another component of your healthcare team. And last but not least, your family and those who are caring for you at home are one of the most essential parts of the healthcare team. Everyone who is going to be involved in your care, living with you, should be on the same page. So just like you are hearing information from your neurologist and your cardiologist, so should the family also be relayed this information as well. So I wouldn't be being myself if I didn't give you guys an example case and ask you questions on that example case. Not a hard case, but I want to make sure that we establish that we all are on the same page and we got out of this presentation exactly what we were trying to get out of it. So, starting with the case, this is Mildred. Mildred is a 67-year-old woman who has a history of diabetes and a history of breast cancer that was treated in the past with chemoradiation and surgery and is now in remission. Mildred lives with her son and his wife and has lived with them since her diagnosis. About an hour ago, while Mildred was sitting down watching television, she developed a headache. And this headache was followed by a sudden onset of numbness in her right arm, as well as some slurred speech. Now, this episode lasted for about 5 to 10 minutes, and then it eventually went away. Now, Mildred has started to notice these symptoms come back, and they have been present now for the past 15 minutes. But unfortunately, like the first episode, they're still persistent and they have not gone away at this point. Because this is very strange for Mildred, she attempts to get up and walk to the restroom, but as she does that, she notices that she's having some additional weakness now in her right arm and her right leg, which is different than the symptoms that she experienced during the first episode. Questions that I have for you guys. So, if you notice on your screen, you should have the ability to do reactions. If you know how to do this, great. If you don't, if you go to reactions, I want you to raise your hand if you agree with the statement or the question that I'm posing, okay? So for all of you who are participating, do you think that Mildred is having a stroke? Please give me your reaction. You can raise your hand. Nice, nice. Okay, is this a medical emergency? You can give me a thumbs up or raise your hand. Great. Excellent, excellent. I see Timmy with a thumbs up. Okay, so what should Mildred do first? Should she A, take a nap? Should she B, call 911? Should she C, walk to a neighbor's house? If you say A, raise your hand. If you say B, raise your hand. Call 911. If you say C, walk to a neighbor's house. So what should she do next? After she does her first plan of action, should she have a seat? Should she go ahead and take a nap because she's tired? Or should she take a Lortab because her head was hurting after all and she really doesn't want to have a headache? Should she do A? Who says A? Who says B? Who says C? Smarty pants. Okay. So can you tell me, what does FAST stand for? Does it stand for face, ankle, sight, time? Raise your hand if it does. Does it stand for forehead, arm, speech, touch? Timmy, that's a no. Does it stand for face, arm, speech, time? Give me a thumbs up or raise your hand. Is it C? Very nice, very nice. Lastly, do you believe that Mildred had signs or symptoms of FAST? Raise your hand if you agree. Do you think she did not? Okay, she did. She did. Great. So yes, Mildred has a number of risk factors, as we talked about here in the slide before. She's a 67-year-old woman, so she's in the age group that's going to be higher risk for developing a stroke. She's a woman in a higher age group. And from the picture, we can assume she's probably a person of color, which she is. So she has more of a risk factors. She also has had breast cancer in the past with chemoradiation. We didn't discuss this, but these are also risk factors as well for stroke. So she developed symptoms that lasted for 10 minutes and went away. Those symptoms probably that she experienced in the beginning was a TIA or a mini stroke. She experienced them, they lasted shortly, and then she went back to her baseline. But at that point, she probably should have went ahead and called for help or picked up the phone herself and called 911. Instead, she waited and then developed the symptoms again. So in between the first symptoms and the redevelopment of symptoms, there was probably about 45-minute time period that transpired. So absolutely, she developed FAST, which was facial weakness, arm weakness, speech difficulty. She notes that she had some slurred speech. So it is of the utmost importance at this point that she get in touch with her emergency professionals by calling 911 and get to the hospital immediately. Now, there may have been some confusion about what should she do first. She should call 911 immediately first. She should not try to walk anywhere. If she has access to the cell phone, she should call right then. If she has access to someone in the house that can hear her, she should call out for help and have them call 911. In the event that she's unable to do that, she should then try to seek out help if she's able to walk. But in the second question, if she's able to call 911, her next plan of action should be to rest, to sit down, to not cause any further injury, because if she develops weakness, which she did mention that she developed weakness later on, she has a higher risk of a fall, which could result in worsening injuries such as fractures or even brain injury. So you guys did great. Wonderful answers to all of the questions. I just wanted to provide this slide so that if you wanted to have any further information about stroke, you can reach out to these websites. American Heart Association and the American Stroke Association are two important groups or organizations that do a lot of research and outreach in terms of stroke education for patients. The CDC is also a site that can provide you information, particularly on the economic impact of stroke in terms of how much money we spend a year, and in terms of the numbers. You should be able to find that on the CDC website. And then your NIH organizations as well are very important to provide information for you. So with that being said, again, I want to thank you all for having me do this talk. And at this time, I will be happy to take any questions.
Well, first off, I just want to say thank you. This was so comprehensive, and I, God forbid, if I'm ever in an instance where, you know, a family member or someone I know has a stroke, I feel like I know what questions I need to ask the physician in terms of where they are in the procedure. So I guess my question is, after saying that, is what happens when, let's say a family member has a stroke and you find out that these things, they did, the medical procedures did not happen as quickly as they should have. And not that anyone would say that, but how do you help advocate if you're feeling as if there is not adequate medical treatment for a family member?
I think the part about stroke is that you have definitely different multidisciplinary teams. So you have an emergency room physician who's involved, and you have the EMS tech who also has a big role in your care or your management once a stroke is thought to be happening. You also have the neurologist that has to come to the bedside and the neurosurgeon. So there's a lot of steps along the way where things can, be slower than others. Also depends on what facility you're in as well, and how readily available there's someone who can actually take care of what's going on with you. A lot of times a patient may be in a facility that doesn't have a higher level of care if it's needed, such as a neurosurgeon. So that patient may have to be transferred to another hospital. So all of these things together can cause, a lag in care. If there's a question about whether or not that lag of care was preventable, then I think that number one, it's helpful in some sense that you have a lot of individuals that you can talk to, because you have your emergency room physician, which more than likely you've had a conversation with, the family member has had a conversation with, if they're doing their job and making sure that they're keeping lines of communication open with you. And you also have the neurologist and the neurosurgeon, if they're involved, that you can also ask and express your concerns. But if you feel like your questions or are getting answered, to make you feel comfortable, then there's always hospital advocates that you can reach out to. And most hospitals have a patient advocate that you can express your concerns to, and they should address those concerns. It's their job to.
Thank you very much. We have another question in the chat box from Ms. Jeanette. Is it possible to temporarily lose sight during a stroke?
Yes, absolutely. So there's different areas of the brain that are responsible for vision in different ways. If I just wanted to pick one right off the bat, is your occipital lobes in the back of your head. So we talked about the carotid blood circulation, which run up on the front of you, the side of your neck, and supply most of the blood to the front of your brain and to the middle of your brain. Then you have blood vessels in the back called the vertebral arteries that run along your spinal column. And those supply blood to the back of your head. And many of those areas in the back are responsible for your vision. So if you have a thrombus or a clot that gets lodged into the arteries in the back, then you could definitely have changes in vision. Now, if that clot doesn't stay there very long, or if you have stenosis in that area, in your vertebral arteries, and your blood pressure drops, so it's not pushing blood up to the back of your brain like it normally would if you had normal blood pressure, then you can temporarily lose, have temporary defect from loss of or decrease in blood flow to the back of that area. So at the point when your blood pressure increases back again, you may, those symptoms may go away. So TIAs can definitely happen and manifest as changes in your vision. So again, when you notice those symptoms, you should be alert and you should immediately call for help. It's better that you're safe than sorry. If you get to the hospital and they say your vision was caused from something else, fine. At least it wasn't something that could, have detrimental effects in the long run, that you just didn't, take it seriously as you probably should have. So.
Well, thank you so much, Dr. Jill.
You're welcome.
And this was magnificent. I hope you guys that joined us, we really thank you for your time. We hope that you will join us again tomorrow. We are going to be discussing health disparities in the African-American community, specifically to the African-American woman. So I just want to thank you again. We will have Dr. Corinne Schumer with us tomorrow, PhD, and this has been absolutely magnificent. So again, thank you for your time, and we hope to see you again soon. Bye, guys.
Thank you. Bye.
Bye.